Welcome everyone to our Thursday webinar series. We are so glad that you're here with us today. My name is Lourdes. I am the Director of Patient Services with the Cholangiocarcinoma Foundation. As a reminder for our webinars, if you have any questions, please enter them into the chat or the Q&A. And please make sure that your questions are general in nature, not specific, because our speaker cannot answer specific questions to your case. And I'm going to introduce to you Dr. Jeremy Kratz. He is a physician scientist who investigates hepatobiliary malignancy using patient-derived organoid models. He serves as lead for gastrointestinal cancers with the Veteran Administration's National Precision Oncology Program and National Gastroenterology and Hepatology Program for liver disease. His interests include early phase therapeutic development and ex vivo models for predicting targeted therapeutic resistance. Thank you, Dr. Kratz, for being with us. I'm going to hand it over to you.
Perfect. Thanks so much, Lourdes. It really is a privilege to share the work that we're doing here at the VA, but also, it's always a privilege to be part of such an amazing organization as the Cholangiocarcinoma Foundation. I'm a GI medical oncologist here in Madison, Wisconsin, but I also work with the VA nationally, leading some of our GI precision oncology efforts. And so today I wanted to talk to this group specifically about the landscape of actionable molecular alterations in veterans with advanced cholangiocarcinoma. The VA's healthcare system is the largest integrated healthcare system in our country. And so it does provide kind of a comprehensive view of molecular profiling, which we think provides significant value to this community in understanding the actionability of these cancers, and also really mapping out this from a large healthcare system. I'd like to start, these are my disclosures. I do have a very active clinical trial portfolio that spans specifically early phase development. And so I do work with these groups in order to bring forward trials for patients with advanced solid organ cancers. So the VA's National Precision Oncology Program was established in coordination with the Moonshot efforts. And with that, there was a transition from traditional medicine, where we try to align radiation, chemotherapy, and surgery towards the goal of improving outcomes, versus really integrating genomic cancer testing as really the forefront of how we treat cancers. And I think cholangiocarcinoma is one of the cancer types where this has been so paramount. Oftentimes when I'm making a decision for a patient, I want to know that molecular profile even before considering frontline strategies, because of the opportunities we have to provide precision-based treatments, either in the form of an early phase clinical trial or in the form of planning kind of those next steps of therapy. And so this effort was really pioneered, but had to be worked within a given healthcare system. And so similar to a patient's experience within one healthcare system, this effort was actually done nationally. So in partnership with some of the sequencing facilities, Foundation Medicine and Tempus as an example, there was contracts established where a given medical center would physically send the tumor tissue to the NGS testing facility, and we would supply a test requisition. But out of that, of course, the report is going to be provided back at the local level to the medical center. However, with that, there's a large amount of data that is generated, both clinically annotated alterations of the cancer, as well as the absolute read calls, which can provide additional data sets beyond that, which are summarized in, say, a PDF report that your medical oncologist may have. And so the oncology program within the VA nationally recognized the value of this in both, establishing these relationships, but also providing these data to be annotated and structured for researchers such as myself to locate and to summarize. And so within the VA structure, there's a corporate data warehouse, which is a centralized repository for a significant amount of national VA data. And that also can be requested and linked back to individual medical centers. And so while locally, I send NGS on my veterans with advanced cholangiocarcinoma, at a national level, if there's significant interest in how we can map and understand the therapeutic vulnerabilities of these cancers across the diversity of veterans here in the United States. So our study design that we'll talk about today was presented at the GI Symposium. I had connected with Juan Bali, who I see is on the call here today, and he said, you should share this with, with our audience. And so essentially across 126 VA sites that participate in the National Precision Oncology Program, we looked through the VA's central data warehouse and performed a retrospective analysis of over 483 individuals, and we annotated for cholangiocarcinoma, the primary tumor location. We think that this is so important, and I think national efforts really need to make sure that these are well annotated to clarify between intrahepatic, hilar cholangiocarcinoma, and extrahepatic cholangiocarcinoma, as well as for gallbladder cancer, because we believe that they're distinct entities and that each cancer type has a unique disease biology. From there, we also did an individual chart review of all 483 cases to look at overall survival. I think that from a patient-centered outcome, overall survival is very important. And so, in considering the analysis of this, while it is real-world data, it's not in the form of a clinical trial, it does have an endpoint of overall survival, which we think is the ultimate endpoint that we're hoping to advance in all our research efforts focused on cholangiocarcinoma. As you can see, this population had a large male predominance consistent with the US military population. There was a predictable age distribution, including a majority of veterans between the ages of 65 and 75. There was a good mix between both localized and metastatic cancers at the time that NGS was sent, and there was a predominance of intrahepatic cholangiocarcinoma, as is known as the most common clinical presentation for this cancer type. A majority of veterans, over 2/3, had served during the Vietnam era, but there were also veterans from other areas, including a large proportion of individuals who served during the Persian Gulf era. In patients with localized disease, they had improved clinical outcomes as compared to those with metastatic disease, which for a real-world population is in alignment with our understanding of this disease process. Importantly, the start time for this Kaplan-Meier curve was at the time of diagnosis. So it was at the time of a pathologic diagnosis of advanced biliary tract cancer. And so while NGS sometimes is sent, this sequencing testing is sent later on in an individual's course, the diagnosis and the survival was defined from the time of their initial cancer diagnosis. What you can see is that there were some differences in terms of treatment outcomes. We did pull out both ampullary and hilar cases, showing that those individuals had improved survival relative to intrahepatic, extrahepatic, and gallbladder cancer in our population. And we think that this is likely attributable to the Whipple procedure, which sometimes can be utilized to, essentially remove the cancer, specifically in localized disease. Because the numbers were relatively small, we didn't do additional subgroup analyses to sort out the clinical presentations in those cases. I think it's also important to note that individuals with hilar or ampullary cancer have a higher propensity to develop jaundice as their presenting symptom. And so it's possible that those individuals could have a higher proportion of localized disease, because things like jaundice are things that patients, families, caregivers can readily recognize and potentially can capture that earlier, whereas in intrahepatic disease, the presentation of jaundice is oftentimes seen in an advanced disease setting. So from this, we stratified the most common molecular alterations. Gosh, this is the genomic slide where there's lots of colors, and I think we've added many different hues to this, so it is kind of a complicated overall presentation, but I want to just briefly kind of map this out for the audience. So to start, we have OS, which is overall survival, and so we've numbered essentially the months of overall survival across our population against molecular differences. And so these are all individual genes. So each one of these columns represent individual genes. And then here we've provided a VAF. So a variant allele frequency is the proportion of time a given cancer mutation exists. And then we use this normalized or NVAF in order to provide the amount of tumor tissue that has a given variant. And we think that this is an important way to standardize the amount of actual mutations in a tumor when we go to look back at research. And this will become more important as we talk about homologous recombination deficiency in the time ahead. So that's the first panel. The second panel looks at copy number variants. So sometimes a given cancer can have multiple copies of specifically pro-oncogenes. The most common one in cholangiocarcinoma is HER2 or ERBB2. And essentially here we've mapped the numbers of times these events were seen across the diversity of our study population. And then there also are important gene losses. CDKN2A is one that is involved in the regulation of the cell cycle, and MTAP is an emerging biomarker in the management of advanced cholangiocarcinoma, where there are some available clinical trials going on at this time. And then lastly, we do report the FGFR2 fusion events, a highly actionable fusion that really is a hallmark of this cancer type where many agents have been developed. And then from there, we also sort out the individual tumor locations. So our largest population is, again, the intrahepatic population, but we also see hilar, extrahepatic, gallbladder, and ampullary cancers all defined. And so summarizing this all together, in considering current national guidelines, including the VA's pathway recommendations for alternative treatments to chemotherapy, we see that microsatellite instability, BRAF with a mutation in V600E, FGFR2 fusions, ERBB2, and IDH1 mutations are all actionable in that after frontline chemotherapy, there are available treatment options. And for our VA population, we see that that represents 21.1% of the entire population. We think that this is really important data to share because this is a large consortium of patients. Sometimes we're concerned that large referral centers, such as MD Anderson or Memorial Sloan Kettering, have a bias for referrals for patients where these are found. And so our specific population, because NGS is standardized for everyone across the United States and is all captured centrally, we think that this could provide a real world view of the actionability, with the exception being, of course, that we have a male predominant population. And so, gosh, we hope that that there's more actionable alterations in women, but in a male predominant population, we see that that represents 21.1% of our US military veterans. From here, we moved ahead and we looked at the individual alterations by site of tumor. For intrahepatic disease, we saw that IDH mutations were seen in 13.5% of the population. And hilar disease, they were not as common. And interestingly, in extrahepatic disease, we saw a predominance of ERBB2 amplified disease at 12.8% of the population, as well as in gallbladder cancer, we saw that 17.2% of the population had this ERBB2 or HER2 amplified disease. And then the top of this graph has what I would consider the 4 actionable biomarkers in the management of advanced cholangiocarcinoma. But we also have to consider other gene changes that are seen in this cancer type. I included TP53, which is a common tumor suppressor in this cancer type, activating alterations in KRAS, which is an emerging treatment strategy through clinical trials, PIK3CA activating alterations, and MDM2 amplified disease, for which the later 3 here all have available clinical trial treatment options in early phase therapeutic development. Unfortunately for TP53, we do not consider a majority of TP53 alterations to be actionable. There is one exception to that through clinical trials with an activating alteration in Y220C, 220C. There are some ongoing studies for a very rare molecular variant representing approximately 1% of TP53 mutant cancers. So while there was a high propensity of TP53 alterations, unfortunately, those are not able to match with trials for a majority of those cases. So from here, we compared the survival in this real-world setting. Importantly, we have to note that this study was performed prior to many of the FDA approvals for targeted therapies in advanced cholangiocarcinoma. And so while we're all, very grateful for the predictive value, the ability to provide a patient a treatment that can improve their survival, we do believe that for a majority of these biomarkers that I'm reporting today, we actually are considering them more as prognostic. And so in a real-world setting, we want to know if these genes are found, is there an improvement in outcome? Interestingly, for the FGFR2 fusions, at a time where few patients were receiving targeted therapies, we did not see a significant difference with the FGFR2 fusions. And we think that this is because a majority of these veterans were diagnosed with these fusion events prior to the availability of these agents. And we anticipate across time that these curves will continue to improve with the available agents such as the FDA approval of pemigatinib, futibatinib, which are both available and important treatment strategies as targeted treatments for FGFR2 fusions. But at this interim analysis, with some limitations in the number of events, we did not see a statistically significant difference in the outcomes at the early inception of NGS for our veterans. When looking at ERBB2 or HER2 amplified disease, we saw that for the HER2 amplified disease, we saw that there was an inferior clinical outcome for our veterans. I apologize, this slide does have a minor error where actually the orange here represents the ERBB2 amplified cancer type. And so unfortunately, we see inferior survival at a time where ERBB2 targeting was not established standard of care. Consistent with prior studies, IDH mutant cancers had improved clinical outcomes. So you can see here that the median overall survival for IDH mutant cancers was 19.8 months versus 10.7 months, which was statistically significant for our intrahepatic cholangiocarcinomas. So to us, consistent with patients that I see in my practice, we think of these IDH mutant cancers as potentially being slightly more indolent in terms of their growth rate. And this is lived out in this real-world retrospective series. MDM2 amplified disease is a growing distinct biomarker for this cancer type. Here, we did not see a statistically significant difference, meaning MDM2 amplified cancers had very similar clinical outcomes when they were stratified by this analysis, which tells us that if we see a signal of activity, say in a clinical trial targeting MDM2 amplified disease, that likely is of great value for the field. But here we did not see a difference in what I believe to be the largest retrospective series of MDM2 amplified cholangiocarcinoma. PIK3CA alterations, unfortunately, were found to have inferior overall survival. PIK3CA is currently under investigation in clinical trials, but the ability to target this is still kind of ongoing at this time. But it is one of the more common alterations that we can see in this cancer type. Studies like NCI Match have investigated targeted therapies against PIK3CA. And unfortunately, we do see that PIK3CA mutant cancers have an inferior survival in this real-world analysis. Next, I'm going to talk about homologous recombination deficiency, or HRD. Homologous recombination deficiency is a distinct molecular subtype that represents the inability for the cancer's DNA to repair itself. There are many genes that have been defined across cancer types, including breast, prostate, and pancreatic cancer, where given cancers can have loss of function and homologous recombination. Those can occur for a variety of reasons. It can be somatic or random acquired mutations that happen as a function of the randomness that comes with the development of cancer, or sometimes these can be associated with hereditary germline carrier syndromes, the most common being BRCA1 and 2 in diseases like breast cancer. And so shown here are a variety of genes that have been associated with homologous recombination deficiency. And we plot the frequencies with which those are found here with higher proportions of those mutations shown with kind of a white color here. What you can see is that ARID1A is the most common variant that we see in the HRD structure that can be altered in a large proportion of this population. We also can see the inability to identify these gene losses. And so shown in red are complete loss of these genes for a few additional targets that are plotted. And then I show the corresponding gene alterations in both tumor suppressors and pro-oncogenes, as well as gene amplifications that coexist in the context of this distinct population of homologous recombination deficiency altered cancers. So let's talk a little bit about varying allele frequency. And I apologize, but this is a little bit of a math exercise today. But I think that this is like designed for the medical oncologists in the room, but there is some additional data if you pick up your molecular report that individuals consider. And so when you pick up a molecular report, this VAF refers to the variant allele frequency. And so for a given pro-oncogene, we think of these more like kind of a spark plug for the cancer. These oftentimes can be acquired with somatic activating genes. And what that means is that it only takes one copy of these genes to be activated in order for the cancer to have kind of a growth advantage. And so, for example, if you pick up the report and you see a low varying allele frequency, say 20%, we have to map how much of the cells that are tested are tumor and how much of them are stroma, and kind of use that to back predict the varying allele frequency. And so for a sample that's 40% tumor, if the varying allele frequency is 20%, that tells you that half of the tumor reads are there. And our interpretation would be that this is somatic and it would be heterozygous. However, sometimes there's more complicated changes. For example, a chromosome could be lost in a given cancer. This can happen for a variety of reasons. And when that happens, we call this loss of heterozygosity. And so sometimes when you look at the absolute read calls, they can actually be lower than what you would predict they would be because you don't have the second normal copy of TP53. And so if you were looking for 20%, but you had loss of heterozygosity because part of the cancer gene was lost, maybe that number is bumped up a little bit. Shown here is a representation where you've lost that other arm of the chromosome. And with the read calls, you would predict that that 25% would point towards more loss of heterozygosity. As an alternative, you also could have a germline variant, and this is where the math gets a lot more complicated, where you can have both germline variants on their own, which would be present in every cell of the body, representing 50% of the overall content of your sample. And these calculations can be much more complicated. Now, thankfully, we can do a blood test to look to see whether or not a given cancer gene is germline, because we don't anticipate a high proportion of tumor cells in the Buffy code or the white blood cells. We can use that as important information if there's a concern for there being a germline association in a given cancer type. So what we looked at was for any of the HRD alterations, were there differences in the overall survival for our veterans with cholangiocarcinoma? And when we looked at all comers as having an alteration or not, we did not see any prognostic difference in the outcomes of survival across our nearly 500 veterans. Importantly, we did look at the frequencies of these gene changes as stratified by the normalized variant allele frequency. We saw that approximately 3.3% of our veterans had more than 50% of the read calls as variants. And those are distinct populations where we start to get more concerned about either a germline variant or loss of heterozygosity. We think that those are likely the cancers that would benefit the most from either causing more DNA damage, the mechanisms by which platinum chemotherapy work, or potentially the use of a PARP inhibitor, medications that, again, help to impair the ability of the cancer to recover or repair its DNA, trying to kind of force the cancer into an extinction vortex whereby it can't recover from the given damage that exists. But this raises the question of, well, why are these differences there? And specifically, we are particularly interested in whether we can map this against other biomarkers that are in development. In diseases like pancreatic, prostate, and ovarian cancer, there have been homologous recombination deficient scores that have been in development. Foundation Medicine recently reported their HRD score as integral to their biomarker testing platform. And so we're particularly interested, as kind of our future direction of this research, to understand what is the frequency of the HRD score in real-world outcomes to platinum-containing chemo, and potentially could that represent a distinct population of, say, 5 to 10% of the population of cholangiocarcinoma, where we would use specifically platinum chemotherapy earlier in the treatment algorithm, and also consider clinical trials with things like PARP inhibitors or other agents that impair the ability of the cancer's DNA to repair itself. This is a historical study that was out of Japan, where they looked at germline homologous recombination deficient variants in advanced cholangiocarcinoma. What you can see from this limited population-based study was that patients with HRD variants were diagnosed at a younger age across this Japanese population. And you can see that there's a huge diversity in the given variants that we're seeing with germline variants across different cancer types. Across this entire study, it was predicted that about 5.5% of cholangiocarcinoma had a germline variant of HRD. I'm unaware of data within the US population to define what that is, but I do think that this is an important molecular subgroup and potentially a new frontier to consider for clinical trial development. Just this past month out of Europe, there was a study looking at HRD mutations across a European population. And similar to our work, they found that mutations were quite common in the homologous recombination machinery. Those represented approximately 33% of all cholangiocarcinoma. Now, I think it's important to note that just because you have an HRD mutation doesn't necessarily mean that you have functional loss of the machinery of homologous recombination. I think that that's a really important distinction because sometimes these are very, very minor events or subclonal events where they're not necessarily fully responsible for that. And if you have a copy of the second allele, oftentimes that's enough to have the functional ability to repair your DNA. They looked at the progression-free survival in those HRD mutant cancers, and what you can see is that from the time of starting platinum-containing chemotherapy, there was a similar outcome, meaning that patients were on those therapies for a similar duration of time. Interestingly, in the cancers that had mutations in HRD, they were found to have improvement in overall survival across that population. Now, as a medical oncologist who treats this cancer, I wonder if this is played out because the standard platinum chemotherapies in my practice include the use of cisplatin in the frontline setting and oxaliplatin as part of FOLFOX chemotherapy in a second-line setting. I wonder if the use of both platinums help to kind of improve or push up the ability for these individuals out of Europe to survive. Now, this is retrospective analysis, and it does include a small number of patients, only 25 patients. And so, unlike clinical trials where we have kind of a start time at the same point, I think there are significant limitations of this work, but I do think it's a really important starting point in terms of how we think about HRD and potentially trying to define a more distinct molecular subgroup of individuals with this given gene change. As we know, a given molecular profile often contains 3 to say 6 individual activating alterations in our cancer. And so we also explored the prognostic significance of other gene mutations. We saw that mutations in TP53 had more serious outcomes. We saw inferior survival for cancers that were mutant in TP53. Interestingly, KRAS mutations were not found to have inferior outcomes for cholangiocarcinoma in our veteran population. And this is different than diseases like colorectal cancer, where we do see inferior survival when we have mutations in KRAS. Next, we looked at the interaction between homologous recombination deficiency and TP53 mutations. So shown here is a simple bubble diagram where we plotted the frequencies of whether there were mutations in homologous recombination or whether there were mutations in TP53. So if we considered these to be mutually exclusive, we would expect the ratio of the bottom bubble to be the same as the top bubble. But interestingly, we saw enrichment in these 2 distinct populations. And so we saw that TP53 mutations existed with a lower frequency of having concurrent HRD, with a higher frequency of having an HRD wild type status. On the contrary, when we saw HRD mutations, we saw a lower frequency of TP53. And I think that that's important because if we're going to develop new agents to help really take advantage of genes like ARID1A, which are common in this cancer type, we have to consider that the TP53 wild type population exists. And I think that that is an important covariable that we have to consider in the statistical plan when we think about a clinical trial. For the TP53 wild type population, there were no differences in outcomes in cancers that had mutations versus a wild type status of HRD. However, when we stratified by the TP53 mutation status, when TP53 was mutant, interestingly, we saw that the co-mutation of HRD and TP53 had an inferior clinical outcome, suggestive that potentially the addition of these two mutations together was of concern. However, this is a retrospective analysis. I think you could consider other reasons why multiple genomic abnormalities could occur in a given cancer. But I do think it is an interesting subgroup that has an unmet need to develop novel therapies. We also looked at the interaction of homologous recombination deficiency with KRAS alterations. For KRAS wild-type cancers, we saw no difference in the HRD between mutant and wild-type. We also didn't see that discordance in terms of study populations between the HRD and the KRAS overlap. We saw that these were closer together in terms of the distribution of distinct molecular subtypes. So in summary, as we know, next-generation sequencing remains a standard in advanced cholangiocarcinoma. We think that this is an important opportunity both for patient care, first and foremost, identifying trials across the nation, but also an important opportunity to further research about emerging biomarkers in veterans and all patients with this cancer type. Real-world data suggests that over 20% of veterans with cholangiocarcinoma have an actionable molecular subtype. And while we hope that that number is higher, I think it does require an honest view of this across a large integrated healthcare system, such as the VA. TP53 is a critical need in the management of advanced cholangiocarcinoma, and unfortunately, we did identify that it was a negative prognostic marker in our VA population. We have to clarify what the significance of these HRD mutations are, specifically as we think about the ability to target mutations in HRD for germline variants or variants with loss of heterozygosity, where we would predict that agents like PARP inhibitors or next generation inhibitors of DNA repair could be integrated in a more personalized strategy, while also prioritizing the use of platinum chemotherapy for those cancer types that are most sensitive to DNA damage. And then lastly, we've identified this distinct population of homologous recombination deficient mutant cancers that are TP53 wild type. And we look forward to analyzing this across mutational scores, including the HRD signature, in order to help delineate this distinct population, to try and find another piece of the pie to help patients with this cancer type. This is our Center for Human Genomics and Precision Medicine. This is not a live view. I assume that there's probably folks these days that can give talks with a live view, but I think my office is somewhere up in this area. But we are here at the University of Wisconsin, located as close to our hospital as possible to continue to move forward with translational research. This work was supported by a variety of sources. The VA has been instrumental in the growth of my early career program. I've also had work supported from Conquer Cancer and the Doris Duke Charitable Foundation for some of our patient-derived organoid models. This is really a national effort in precision oncology. And I provide kind of a list, and I've certainly underrepresented our National Precision Oncology team, including Dr. Michael Kelly, who's just been a huge pioneer for precision oncology across our VA's network. With that, I'm happy to take any questions and keep this conversation going.
Thank you so much for the research that you do and presenting to the community. If anyone has questions, please enter them into the chat or the Q&A, and we have a couple that came through. Do veterans undergo more regular health checks or screening than the general population?
That's a great question. I think it's really about having a great relationship with in with your primary care physician. When I think about cancer prevention, I think it starts with knowing your primary care provider and knowing, hey, something is different in this scenario. There are many automated tools that are part of primary care within the VA's integrated healthcare system. Specifically things like alerts for the timing of colonoscopies are part of those systems. But I think every healthcare system is unique in how they deliver primary care. And the hope is that the relationship with the primary care remains paramount in the prevention of future cancers.
Platinum is a standard of care in cholangiocarcinoma. In your opinion, is this because of the HRD subgroup?
Can you repeat the question? I'm sorry.
Platinum is a standard of care in cholangiocarcinoma. Is this because of the HRD subgroup, in your opinion?
So we think that the mutations found here are largely developed as cancer develops. And we don't believe that the use of platinum chemotherapy confers the development of these mutations. We think that these are things that develop spontaneously when the cancer develops, or as a function of that rare subtype, 5% of the population that have, say, a hereditary risk for this cancer type. But we don't think that platinum is really driving that difference.
Okay. Do veterans have a higher occurrence rate with cholangiocarcinoma than the general population?
That's a great question. I do not know that information off the top of my head. I think that is a fantastic question, Michelle. I really appreciate that. I would be more than glad to provide you follow-up on the epidemiology of that across veterans. I think it's an important question, and I also think it's an important question specifically for individuals who served within burn pit exposures or within the Middle East. I think that's a really important area of research that we take quite seriously across the VA. But I don't know that answer off the top of my head.
Okay. Cholangiocarcinoma represents what percentage of total cancer patients in the VA?
So cholangiocarcinoma remains a rare cancer type across the VA. As a function of the total cancer percentage, it is quite rare. You're absolutely correct. There are larger incidents of cholangiocarcinoma in states, including Michigan and Wisconsin. Those are data that I'm intimately familiar with. As a provider here in the state of Wisconsin, in a tertiary referral center. There was work previously published by an investigator at Arizona where they looked at the epidemiology of that as stratified by individual states. And I will try to pull that up and include that in the chat. But the regional differences have not been explored within our populations. And I think that that is appropriate because the numbers that we have here are defined across the VA with numbers in the hundreds versus, say, the thousands of individuals that are included in things like Medicare registry data that are used to define the maps of distribution across time. I think those types of numbers are needed to be accurate about, say, enriched pockets of this cancer developing, as is the case, say, in the upper Midwest.
Okay. Do you find that patients who use the platinum-based chemo drugs have an increased risk of neuropathy?
Neuropathy is a very important issue around quality of life. And I would encourage any patient on this call to continue that discussion with their medical oncologists about the risk and benefit of of continuing platinum-containing chemotherapy within the context of their quality of life. I did include the reference. So there's a reference for the epidemiology of biliary tract cancers in the United States over the past 15 years that was published by Rashna Shroff. I did include that link, which includes some maps about where these cancers are developed spatially across the United States.
Perfect. Thank you. I don't see any other questions at the moment. If anyone has any other questions, please again enter them into the chat or the Q&A. Curious question, do you feel like your research after this will continue to be specific to those different biomarkers in the VA population? Do you foresee it, as you mentioned, looking at those vets who maybe were exposed to different environmental factors during their service, like the burn pits, how you mentioned, like that? Is that somewhere that this research may go, do you feel like?
Absolutely. So my research group is very fortunate where we have the ability to grow patient-derived organoid models from individuals with advanced biliary tract cancer. As we know, each one of these cancer types and each one of these models is unique, and what drives that cancer or what its unique vulnerability can be. And so in my group, we integrate many screening activities for established drugs with known safety profiles or for emerging drugs in development against distinct biomarkers. For example, homologous recombination deficiency can be targeted with a variety of agents in development. And so using a combination of both organoids, patient-derived organoid models, and animal PDX studies, patient-derived xenograft studies, we look forward to bringing forward new concepts, new clinical trials to impact these distinct molecular subgroups. From a burn pit exposure, there are large genomics efforts that are ongoing that use whole genome sequencing within the VA's population. One study that I would highlight is looking at individuals from the Million Veteran Program who have developed advanced solid organ cancers, where there's paired whole genome sequencing between the patient's blood and the patient's tumor. And we think that those could help elucidate whether or not any environmental exposures were associated with the development or were enriched in distinct study populations. Those studies are ongoing at this time.
Okay. I don't know if you have an answer for this, but there's a question if asbestos exposure is a high risk for ICC for intrahepatic cholangiocarcinoma.
I'm not aware of that data. Whenever I have an individual who has a distinct exposure, I do think it's worthwhile to sit down with your medical oncologist and maybe try and set an extra 20 minutes aside so that we can really review what's available in the literature for any environmental exposure in order to fully answer that question. But off the top of my head, I'm not aware of that in a veteran population, but certainly is an active area of inquiry, ultimately that is answered through epidemiologic studies, which is not my particular area of expertise.
Thank you. I don't see any other questions. So I just want to, again, thank you for presenting this information to the community. I appreciate your time, and thank you for answering those questions that did come through.
Sounds good. Thanks so much to the Cholangiocarcinoma Foundation for the invite today. It's really great to integrate with all your efforts. I have the squeeze balls in my clinic, and I probably wear your wristband all the time. My daughter's like, why are you wearing this wristband? But I do think the work you do as a community is incredible, and As always, if there are specific questions that I can answer in follow-up of today's talk, don't hesitate to reach out.
Thank you so much. Thank you everyone who was on the call today. We appreciate you being here with us.